welcome. This is Marika from Herasphere, and today I'm so excited because I'm here with Esme Soan, who is going to be talking about the role of exercise in the management of gestational diabetes. Thank you so much for joining me today, Esme.
Oh, thank you very much for having me.
Oh, you're welcome. Before we get started on the questions, though, I'd love it if you could just talk a little bit about, what an exercise physiologist is, because a lot of people don't know what that is, and tell us a little bit about your sort of clinical experience so that people can understand why it is that I, poached you for this interview.
Yeah, no worries. So exercise physiologists, we are fairly new to the allied health game. We complete a 4-year degree at university. We're registered as allied health professionals, just with Medicare and all those things. And we essentially use exercise as medicine. So we look at the way that exercise can affect different systems in the body, whether that's musculoskeletal, cardiovascular, metabolic health. And we're very strategic and prescriptive in the way that we use exercise to place stress or remove stress on all those different systems. So we work in really well with manual therapists like physios or osteos or chiros, and help at sort of increasing someone's exercise capacity and sort of helping them get back to normal movement.
Fantastic.
So we use exercise. Oh, sorry. Exercise is medicine.
Oh, absolutely. I'm all over that. I love it. Love it.
Yeah.
Tell us about the clinics that you're working in at the moment.
Yeah, so I'm working across a couple of clinics. I work for Pair Exercise Physiology, and I also work with the Brisbane Family Clinic, which is a multidisciplinary clinic in with some osteopaths and lactation consultants. When I'm not working as a clinician, I'm the director at the Women's Health Collective, which is a platform for education for a whole range of allied health professionals who work in the women's health field. And we're slowly taking over Australia. We're in Brisbane and Sydney.
Coming to Perth soon.
We'll try.
Going to bring it west side. West side.
Yes.
Awesome.
Yes.
And tell us a little bit about that research that you did with Marta.
Yeah. So as a fresh graduate, I went straight into work in research, and I was looking at the role of exercise physiologists working within a larger multidisciplinary health team, but also specifically looking at the role of exercise physiologists and exercise in the management of gestational diabetes. So just how we might be able to fit in with the current care team to help to improve the care and management of some of the ladies who were diagnosed with gestational diabetes.
Brilliant. And, Esme and I were talking a little bit off air, can we say, about how across the board, and it's the same here as well, the diet aspects are often relatively well covered, can we say, but exercise is usually a little bit of a token prescription of like, here's a sheet of paper or here's a bit of vague advice, but on the whole, I don't find it's managed particularly well from an exercise point of view within the current model of care.
Yeah, it's very much the 30 minutes of physical activity, where people go, what if I can't find 30 minutes in my day? Or what is physical activity? Or just unloading the dishwasher and running after my kids count?
Yeah. It's quite vague, really, isn't it? Tell me, Esme, like, what drew you to women's health as a new graduate? Because it's not an area. It's often, I find, it's an area that people tend to move into after they've had children, and potentially have some issues of their own, or maybe it becomes a little bit more, relevant. But what drew you to it? What made you passionate about this field?
It was actually an assessment piece that I was given as an undergrad. So at uni, I had to write an exercise program for a special pop, and that covered sort of pediatrics, older adults, and pregnancy. And I was by potluck given pregnancy, and I was just fascinated by all of the different physiological changes that occurred in a woman's body to be able to carry a baby. We usually think of the musculoskeletal changes and sort of the very obvious popping of the belly, but the kind of changes that happen in your cardiorespiratory system, your heart beats faster, your lungs breathe deeper, your metabolic system, and we'll talk a little bit about that in terms of how that then affects gestational diabetes. But hormones, mental health, everything changes. It's incredible. So I was hooked. I just couldn't believe I thought it was magic.
Well, it kind of is, really, isn't it? It's pretty phenomenal. It's a phenomenal process to create a little human being and then to birth.
Yeah, it's pretty kick-ass. Yeah.
That's why we're powerful women. Okay, so can you talk, just because I think a lot of people get confused between the different types of diabetes and where gestational fits in. So can you just describe a little bit about type 1, type 2 and gestational, just so people understand a little bit about the difference?
Yeah, definitely. So I guess to make it really clear of what diabetes is in the first place, can explain a little bit about how this pathway works normally in your body if everything's functioning well. So when you eat some food and we get energy from what's called glucose as part of that dietary intake, and that glucose goes around your blood and helps sort of fuel every cell in your body. All of those cells, I like to explain, have a front door to them. And for glucose to be able to get in that front door to go do its job, it needs a key. Yeah. And within our body, that key is a hormone called insulin. So insulin is produced by beta cells that live inside an organ called your pancreas. And so in a normal functioning system, you eat food, glucose is released into your bloodstream. Insulin is then released into your bloodstream to go open up all the doors of all the cells to allow glucose to go in and then be used for energy. In type 1 diabetes, our pancreas and our beta cells are attacked by our own bodies. And so we no longer produce any insulin. So we don't have any keys to open any of the cell doors. And so the treatment or the management of type 1 diabetes is usually with insulin. So you don't have any of your own, so you have to inject or take. In type 2 diabetes, that's where that is a diabetes that can onset later in life, and it's caused by insulin resistance. So the insulin that you have and produce in your body is not working very well in your system. So the key still can fit into the lock of the key, but it's not opening the door very well. So the treatment for type 2 diabetes can be a combination of what we call lifestyle modification, which is diet and exercise, but may also need some pharmacotherapy. So you may also need to take insulin if your beta cells are not being able to keep up with the demand, or other forms of medication.
It's interesting because we used to call the type 2 diabetes delayed onset or mature onset, but
mature onset.
At the moment, we're seeing these changes, and it seems to be coming on earlier than previous decades because of the diet and lifestyle issues.
Yeah. It used to be juvenile diabetes is type 1 and then later onset, but now it's coming around earlier and earlier. And then we're also seeing a big increase in gestational diabetes, which is a kind of diabetes that's with first onset during pregnancy. And it's similar to type 2, but it's definitely not the same. Mm-hmm. So it is still related to that insulin resistance, the key opening, fitting into the lock, but not quite opening the door. Mm-hmm. And it's caused by a lot of pregnancy hormones and pregnancy hormone cascade. So you actually become a little bit insulin resistant in a normal healthy pregnancy. We want you to become a little bit insulin resistant so that there's more glucose and sugar available in your blood for the developing baby. Mm-hmm. But sometimes if there is any level of insulin resistance or sort of beta cell damage where your beta cells that produce the insulin in the first place are already working overtime, then it can sometimes cause those blood sugars to rise a little bit too high. And that's where we see gestational diabetes being diagnosed. And gestational diabetes responds really, really well to lifestyle modification, so diet and exercise. But it is also commonly treated with pharmacotherapy, so medications as well.
Awesome. Okay, Esme, can we talk a little bit about some of the potential complications of having a poorly managed gestational diabetes sort of diagnosis? So why do we want to get these blood sugars in that optimal range?
I guess there are risks for both mum and baby with uncontrolled blood glucose levels. And the sort of number one thing that we're trying to monitor is how big the baby's growing. So it's called macrosomia. So it's different to large for gestational age, which is a term that's commonly thrown around. Macrosomnia is a very large baby. And so if your baby's growing too big, it just means that you are at a higher risk for birth complications, perhaps emergency C-sections, shoulder dystocia, which is where Bob's shoulder gets caught in the vaginal canal. There's also a risk of jaundice for the baby, or hypoglycemic readings in baby, so they may be whisked off to PICU or NICU for a little bit just to help manage their own blood sugars. And for women, there's a risk of sort of gaining a little bit too much weight during their pregnancy, so excessive gestational weight gain. There's a heightened risk of preeclampsia. And then there's a really heightened risk of developing type 2 diabetes in the first sort of 5 years after having their baby.
And does that risk change when it's better managed?
Yes.
Yeah.
So you can reduce
getting this blood sugar under control.
Yes. So you can reduce your risk of developing type 2 diabetes postpartum if you look at lifestyle modifications. So changing how you're eating, how you're exercising, and keeping those changes. So long-term change.
Yep. Fantastic. Yeah. So I think, we were talking about this before, but it's so important to get this management right. And obviously the doctors are so on board with the monitoring and making sure that the blood sugars are kept well, because obviously the baby, if it's just getting dosed with truckloads of sugar, it puts their system under a lot of stress to try and keep that under control. And then, as you said, this hypoglycemic attack afterwards, because they're used to having dosed with so much sugar, and then they're born and their blood sugars just take a dive. So it can be quite dangerous for the baby.
Yeah, and it's one that I always like to explain to my patients, that what can and can't cross the placenta barrier. So your blood sugars do cross into the baby, but your insulin levels do not. So babies having to produce their own levels of insulin to manage their blood glucose. And so that's why sometimes
their little pancreas is going nuts.
Yeah.
Okay, cool. So in my previous interview with Lily Nichols, we talked a lot about real food and nutrition for gestational diabetes. So if anyone hasn't seen that who has GD, definitely go check it out, because we covered a lot of great stuff in that. But for you, because obviously your speciality is exercise, so how does exercise help women with gestational diabetes? Like, what's the mechanism there?
Yeah, so as I was talking about before, all the cells with their little doors, and how insulin is the key that opens those doors. So in insulin resistance that we see in gestational diabetes, the way that I like to explain of what's happening with the doors is that insulin, the key, is still fitting into the lock. It's unlocking the door, but the door's got sticky hinges. So it's just not opening very easily to insulin. And so what happens then is insulin calls back to the beta cells in the pancreas, and it's like, hey guys, I need some more help. Can you send some more insulin out? And so your body is having to produce more and more insulin. And sometimes those beta cells just cannot keep up with the demand. Exercise works incredibly well in managing that blood glucose and clearing it from the bloodstream, because it bypasses the door completely, and it actually opens a window so that glucose can enter the cell. And that's why we see such a great response in using exercise as medicine for both type 2 diabetes and gestational diabetes, because it completely bypasses the need for insulin. So when we exercise and we cause our skeletal muscle to contract, and that's the common in exercises like strength training or weight-bearing aerobic exercise, then it's that contraction of the cells that forces a little sort of spidery looking thing, if you look on the clinical models, to migrate to the cell wall and then open that window. So GLUT4 will migrate to the cell wall, and then the glucose will jump in. So that's how exercise is used, and it's magic medicine.
Awesome. Can we talk about, because people want to know what kind of exercise, and you talked a little bit about strength training and weight-bearing stuff. So is there a particular type and frequency and duration? I know that Diabetes Australia has some recommendations, but I'd love to hear your thoughts based on your research and what your experience tells us.
Yeah, I guess so. The number one kind of exercise that we want people to do is exercise that they enjoy and want to do. So it has to always be something that they enjoy doing, because then there's much more likeliness that they will actually go out and perform it. To elicit that response I was just talking about with the contraction of the skeletal muscle, it's exercise that needs to be weight bearing, and strength training is so important during pregnancy for a whole variety of things, not just for gestational diabetes, but for pregnancy strength as a whole. So weight bearing aerobic exercises, things like walking, things that and cycling. Things that don't work as well are things like yoga, Pilates, or swimming, because we're just not getting the same kind of contraction of the skeletal muscle.
So we want bigger muscle groups involved?
We want big muscle groups involved. Yeah, rhythmic movement. So walking is probably the number one best thing that you can do. You need to make sure that you're walking at an intensity that actually does elicit that response. So the way that we explain intensity as exercise physiologists, or an easy way that is accessible without having, your Fitbit and wired up to heart rate monitor, is to use the talk test.
Yeah.
So as you're exercising, you should be able to still easily chat with a friend or talk on the phone, but you should be just at the level of breathlessness that you're not able to sing.
Yeah.
So you should be working at an intensity where you're like, oh, I'm working pretty hard, I'm getting a little bit of a sweat up, but you're not working to a point where you can't talk at all. So normally that level of intensity would line up perfectly with the kind of intensity that we would want you to work at, to elicit that skeletal muscle contraction and to allow all that glucose to clear out of your bloodstream.
Beautiful. And how long for and how often?
We want to look at solid chunks of time. So 20 minutes as a minimum, 30 to 40 minutes. Unfortunately, sometimes we see recommendations of just increasing your general physical activity. So recommendations like emptying the dishwasher, walking around the house, 5-minute or 10-minute intervals may not always work to elicit the right kind of responses. They're great things to add in to your daily total of activity, but we need to think of it as like an exercise prescription. So it's very prescriptive. We're trying to get a certain response. So 20 to 40 minutes. And timing is all about where we'd see the increases in your blood glucose levels. So whether you have a high spike in your glucose levels after eating a meal, or if you're waking up in the morning with high fasting glucose levels, can sometimes change the timing of which we get you to do your exercise.
Okay, so if someone did wake up and the first thing in the morning they had really high resting glucose levels, would you then recommend that they do it first thing? Exercise.
Depending on how well they then respond afterwards. Yep. It's a bit of a slippery slope of trial and error sometimes. So when someone first starts exercising to control their blood sugars, we look at increasing the amount of monitoring that they're doing so that we can get really good feedback of how their own body is responding, how well their own body can clear their blood glucose, and what the different kinds of exercise how the different kinds of exercise, may improve their response. So maybe one day you pushed yourself a little bit harder. Maybe another day you did a different kind of exercise, maybe a different style of strength training. And all those different things can change how well your body responds. But a general recommendation that I would say, if someone had high post-lunch glucose levels, I would recommend that they go for a walk either before they sit down to have their lunch, or recommend that they go for a walk in the hour or so after they have their lunch, just to help with that blood glucose. Yeah.
So from my understanding, correct me if I'm wrong, after exercise, you have improved resistance or reduced resistance to insulin for sort of 24 to 48 hours. Is that right?
Yeah, that's correct. So people who are using insulin as part of their management for their diabetes or their gestational diabetes have to be really aware that they may do some exercise on a Monday morning, but their body may still be affected on Tuesday night from that exercise session. So it's great. It just shows that how well exercise works as a form of management. Yeah.
And also that frequency needs to be once a week is just not going to cut it. If it's sort of 24 to 48 hours, it needs to be something every day to every 2 days, really, doesn't it?
Yeah, that's correct.
Yep. And how do people monitor? So if a woman's got gestational diabetes and she's been given all the dietary advice, how do they monitor their blood sugars through implementing an exercise program? Is that something that you kind of need to have, an exercise physiologist or a professional to help, or is there kind of general guidelines that you can help with that?
I'd always highly recommend that they work with a diabetes educator and an exercise physiologist, especially if they're first starting an exercise routine, to help with their blood glucose, so that they've got all the right kind of information. So working alongside those two professionals will really help get a clear picture of what's happening and what's working for you as an individual in managing your blood glucose.
Cool. Okay, can you just, I'd love to run through just a couple of case studies, because I think it's really helpful for people to hear other stories. Like we all like stories, but to hear other stories of a couple of clients maybe that you've dealt with that have responded really well to exercise in particular.
Yeah, so one lady who was about 30 weeks pregnant, so she had only just recently been diagnosed with her gestational diabetes, done her oral glucose tolerance test with the nasty fluid to drink. And she'd been part of a pregnancy Pilates class beforehand. So she was a little bit despondent and disappointed at first with her initial diagnosis. And so after just explaining and talking to her about how it's the pregnancy hormones themselves that affect your insulin resistance during pregnancy, so it's nothing that you've done wrong. It's just a side effect, I guess, of being pregnant, one of many pleasant side effects that you can experience. And we just looked at modifying how she was exercising and when she was exercising. So we changed one of her Pilates classes a week to a strength training class a week, where we went through sort of safe levels of strength training exercise, and we upped the intensity of her walking. So her walks that she were performing with a friend, they had a good natter. It was more of a stroll and a coffee than a walk that was getting that skeletal muscle response that I was talking about. So what we did is we managed to tweak a couple of things, and then we saw huge improvements in her blood glucose. So she no longer had high fasting levels when she was waking up in the morning, and she was able to build into her day. Once she had her sort of mid-morning snack, she would go for a walk to help with her glucose levels before she then sat down to have lunch. So she was literally using exercise as her medicine in between her morning tea and her lunch. It was great.
And how much nicer to go for a walk than chuck a tablet?
Yeah, and the interesting thing is there's some medication called metformin, which is sometimes used to manage gestational diabetes and sometimes given as an option for type 2 diabetes as well. And metformin works through the exact same cellular pathway of opening the window as exercise does, but without any of the great side effects that exercise gives you of like increased strength and better flexibility, better mood. So mental health, I could list good side effects of exercise all day, but not many good side effects of medication.
No, not so much. That's awesome. We were talking a little bit briefly before about the long-term benefits of exercise during pregnancy for blood sugars. Can you run through that in a little bit more detail?
Yeah, so I guess the current clinical care pathways for gestational diabetes is quite short-sighted. So really what we're mainly concerned about is helping women manage their blood glucose for their birth. So we're looking at 40 weeks, brilliant, baby's delivered safely, mum's safe and healthy, brilliant, off you go. What we really need to do is look at it long term. So we need to, adjust our eyesight a little bit. It's a really great window of opportunity for mums to change their lifestyle modification, to start exercising, not just increasing their physical activity, but to actually look at structured exercise, change the way that they're eating, and then keep those habits and make those habits their lifestyle so that they can continue doing that once baby's born and down the track. during your pregnancy, and if you get a diagnosis like gestational diabetes, it can be really scary, and it can actually be really upsetting for some ladies, especially if they felt like they were doing the right thing in terms of their physical activity and eating beforehand. So being able to make those changes, and especially under the guidance of sort of the experts like dietitians or nutritionists and exercise physiologists, so that you're doing the very best thing for your own individual body. And then you're able to take those habits through postpartum and then on to the rest of your life.
Yeah.
We're seeing a big increase in type 2 diabetes post the gestational diabetes diagnosis, because there's no changes that are being made at that first GDM diagnosis. And we sort of see GDM as a bit of a red flag. So it's just showing that it's sort of like a stress test on your whole metabolic system. Is it able to cope with this increased demand that pregnancy places on it? And if it's not, then that's when we see gestational diabetes. So it's an early warning sign. It's a red flag for whether or not there are sort of deeper issues already there. So perhaps there's a level of insulin resistance that was already there before you fell pregnant, or perhaps your beta cells are already working overtime, and so they just can't work any harder when the demand increases during your pregnancy. So it's more that we need to look at making changes for the rest of someone's life rather than just making changes for their birth.
I 100% agree. And that's something that Lily and I talked about quite a lot as well, is that there's quite a lot of people coming into pregnancy pretty much in a pre-diabetic state, a pre-type 2 diabetic state, and with the higher levels of obesity and this increased insulin resistance, and then coming into pregnancy where, as you say, there's that increased load on the system. It's that warning sign, and it's as you say, it's a fantastic window of opportunity for health and fitness professionals to kind of get in there, get those lifestyle modifications happening, which yes, will help the birth and the pregnancy, help the baby.
Yeah.
But if the woman feels great, feels strong, recovers well from her birth, gets into that habit of exercise with someone that they enjoy and that they have fun with, then that can be something that they can enjoy long term, and they're going to reap the rewards for decades to come, really.
Definitely. So we need to stop looking at a Band-Aid approach and look at the long term.
Yeah, we're on the same page here.
Yeah.
So yeah, fantastic. So it's really important for women, obviously, to continue with exercise in that long term, not just during that gestational diabetes diagnosis per se, because they're going to be having those benefits long term. Esme, is there anything else that you would like to add just to wrap it all up, or any particular message you'd like to give to pregnant women with gestational diabetes?
Yeah, I think it'd just be to encourage them to connect in with a professional like a fitness professional or an exercise physiologist who can help them with their exercise programming, and not to be scared to try something different apart from just the pregnancy Pilates and yoga. You don't have to be wrapped up in cotton wool, and there's a lot of physical work that's going to be needed from you on the other side when you have your newborn baby. So the best time to start training is right now.
Beautiful. And I completely concur. And over the years, my pregnancy classes have changed substantially, because admittedly I was quite conservative and very much came from that traditional Pilates background. But following people through into the postnatal period and recognizing the physical demand of motherhood, it's not enough to be giving just stretching, in my opinion. Like, we've got to be loading the system. We've got to be strengthening strengthening women within, especially within those functional movement patterns that are required for motherhood, which is one of the reasons why I created my online program, is just to give people that opportunity to do some of that stuff at home. Awesome.
Yeah,
okay, so
definitely.
Esme, if people want to reach out to you, so if they're in Brisbane, obviously they can find you at Pear Physiology, or at what was the family clinic of Brisbane Family?
The Brisbane Family Clinic and Pear Exercise Physiology. So Brisbane Family Clinic is in New Farm in the middle of the city, and Pear Exercise Physiology is up at Chermside near the big shopping centre. Yeah.
And if there's any other fitness professionals or allied health who want to hook up with the Women's Health Collective, definitely join I know I'm on the Facebook page. It's a Facebook group there, and there are regular meetings in Sydney, Brisbane and Melbourne. And at some point, Perth.
I promise I'll come across to Perth. We're on our way.
We're on their way. And so definitely hook up with them, because I think it's really important that we, you know, work together, share our knowledge, and try and disseminate so much information as much information as we can to help improve outcomes for women not only during pregnancy, but, you know, through life.
Yeah, there's a movement happening. Get on board.
Woohoo!
Start talking.
Brilliant. Well, thank you so much, Esme, for chatting to us today.
Thank you very much for having me. Pleasure.
You're welcome. Have a great day.